Hi, everybody. Welcome back to the episode of Ask Dr. Nick. My name is Dr. Nick Schmidlkoffer, and I work for the Neurologic Wellness Institute here in downtown Chicago. On today's episode, we are going to answer the question, what is trigeminal neuralgia? And trigeminal neuralgia just means pain in a nerve, and the trigeminal nerve is the nerve that distributes sensory information to the face. And so trigeminal neuralgia is nerve pain within your face. And there are a couple different reasons why this could happen to people. Sometimes it's idiopathic, meaning that we don't have a source, but a lot of times there are common common reasons why it happens. And so we're going to get into a paper just looking at the diagnosis and treatment and current treatment options. And I'm going to talk a little bit about what we do for trigeminal neuralgia and other places that we look into. So let's get right into that paper. Okay, so here we are. Trigeminal neuralgia diagnosis and treatment. It is from Pathology in 2017. And so I'll go through the abstract, and then I want to go right to a photo of what the trigeminal nerve looks like. So the introduction shows trigeminal neuralgia is characterized by touch-evoked, unilateral, brief, shock-like paroxysmal pain in one or more divisions of the trigeminal nerve. Okay, trigeminal nerve has three divisions. I'll show you here in a sec. But at 1, B2, or there 5, 2, and then B3 goes down here. And it's saying it's touch evoked. So basically, having a little bit of touch to the area causes these brief shock-like pain symptoms. Okay, so a lot of people like wearing masks. That touch can provoke that pain even more. But sometimes it comes down to stress and other things. There's like classical trigeminal neuralgia and secondary trigeminal neuralgia. So what happens is there's a lack of myelination or demyelination of this nerve as it enters maybe the root entry zone or where it enters the brain. And that's the predominant mechanism. A lot of times this demyelination is caused by a neurovascular conflict, meaning that basically an artery is crossing over the nerve and it's leading to lack of blood flow or constriction onto that nerve. That is what's classical trigeminal neuralgia. But then other things that can cause it are like multiple sclerosis, where there's demyelination in parts of the brain, because multiple sclerosis only affects myelination in the central nervous system. And of course, trigeminal neuralgia is a peripheral nerve. Or like a space-occupying lesion, possibly a tumor, that could be causing this secondary trigeminal neuralgia. So it's important when we diagnose it, we have to make sure it's not like a post-traumatic or post-herpetic, so like a herpes pain or other facial pains. And then a lot of times treatment is this prophylactic medication, but those have a lot of side effects, which we'll talk about later on. And so future studies are for sure necessary in order to help determine what's the true cause. So here's the trigeminal nerve, okay? I like this picture because it shows where it comes out of the brain. And so I want to talk about that. But the trigeminal nerve is the fifth cranial nerve. Fifth cranial nerve, so that's Roman numeral 5 or Roman numeral V. And so it's classically determined as V1, V2, and V3. Really, these branches are the ophthalmic branch, the maxillary division or maxillary branch, and then the mandibular branch going down to the mandibular jaw. And so the trigeminal nerve comes out of the pons in the brainstem, and then right out of the pons is a ganglia. The ganglia is where the cell bodies live, and then the branches have all these axons that are going to supply here for V1, the forehead, the eye, the cornea, down into the nose, again back up to the forehead. B2 is going to go into the nasal cavity, the maxillary region, so the upper teeth, and then the B3 is going to go down more to the jaw, the lower teeth, the mandible, underneath as well. and then it also supplies the muscles of mastication, so like jaw muscles. But all three of these come back, again, they bring in this sensory information from the face, and they come back into this pons area, and then tell the brain that there's touch or pain or vibration or movement of the jaw, whatever it may be. And so what happens is, as I mentioned, a neurovascular complaint. So basically, there are arteries that run through here. There's a facial artery that runs through. Commonly, that facial artery is going to block or tighten up on these nerves, and that can lead to a problem. It's a neurovascular compromise. That's classical trigeminal neuralgia. Other things that were mentioned were like space-occupying lesions, whether they're out in the nerve or within the brainstem. And so a space-occupying lesion or a tumor that could be blocking the nerve or affecting the actual part of the brain. So let's say like the midbrain or the pons. And then, as was also mentioned, was multiple sclerosis. That has no effect on the trigeminal nerve itself, but it affects the axons that are running in the brain stem. And so this can lead to this nerve pain, even though it's not coming directly from the nerve. And part of the theory is that this light touch or this touch-provoking pain can be that this nerve is close to threshold. By just a little bit of pressure, a little bit of touch, it's going to provoke more signal and therefore cause pain. And so if it happens within the brainstem, like in multiple sclerosis, or in other central nervous system disorders, then again, how this nerve is connecting to other parts in the brain are also close to threshold. They're not doing as well. They need more blood flow and better stimulation to decrease or to have more stability, so that just a little bit of touch or pressure doesn't hurt or doesn't cause these nerve pains, okay? And so that I really wanted to show, but I want to go back to the paper because the paper has some other good points that we want to discuss here. And so they have basically a criteria. The criteria needs to, have to have at least 3 attacks. The pain has to have 3 of the 4 characteristics, like they're, again, paroxysmal, their severe intensity, their electric shock-like, shooting, stabbing, sharp quality, all like what nerve pain does. They're precipitated by innocuous stimuli, which is just a simple touch. And there's no clinically evident neurological deficit, right? There's nothing else that can describe it. With that subclassification, again, classical TN is trigeminal neuralgia with purely paroxysmal pain or concomitant persistent pain. Symptomatic TN or secondary TN, generally associated with multiple sclerosis, a space-occupying lesion. We talked about those things. And then there's there's just other ways that you can classify it by different organizations. So, okay, then we go down here and we think about where it is. So classically, the localization of it affects the 2nd and 3rd divisions, mostly on the right side, are more affected on the right side. So basically, the 2nd division here in the upper teeth or the lower teeth, okay? I've had a patient who they had a root canal in their 2nd upper tooth, and that is what precipitated the initial trigeminal neuralgia event. So then we have natural history. Again, sometimes it comes on without notice, without anything. But trigeminal neuralgia, this is the key point, it's unpredictable periods of complete remission. It may last months or years. So it may all of a sudden just go away, but then it can come back. This is likely due to, they think, is a reduction in the excitability and partial remyelination. So if demyelination affects trigeminal neuralgia, causes it, basically causes the pain, then if we can do things to remyelinate it, this is where we come in with different treatment options that can improve and decrease trigeminal neuralgia pain that is occurring. Other things that happen with the facial pain are autonomic symptoms. Autonomic symptoms are tearing, rhinorrhea, or a runny nose can happen. Other things, so short-lasting, triggered, stabbing pain, with these symptoms are another issue. This is the challenge for a differential diagnosis. There are two things, SUNCT and SUNA. SUNCT is short-lasting unilateral neuralgia-form headache attacks with conjunctival injection and tearing. So that's why it looks very similar to trigeminal neuralgia, or short-lasting unilateral neuralgia-form headaches with autonomic symptoms. So again, this is why diagnosing trigeminal neuralgia is hard. It's generally an underdiagnosed or misdiagnosed, as it says here. But at the same time, we have to understand, is it true classical trigeminal neuralgia with where an MRI would then find a problem with a artery crossing over the nerve? Is it due to secondary causes, or is it something that's more maybe in the central nervous system that we can help? Incidence is higher in women. It's pretty evident there. Here's just an MRI showing how there can be trigeminal neuralgia due to a meningioma. So like right here, meningioma is affecting the trigeminal nerve. Over here, it's the artery that is looping over the anterior inferior cerebellar artery is looping over the trigeminal nerve, and that's what's causing the compression. And then again, here are some differential diagnoses. So again, we see a lot of concussions at our office, so painful post-traumatic trigeminal neuropathy. That's important to differentially diagnose. Is it truly that or not? And then lastly, some treatment. So MRI is of course important to determine, is it a microvascular issue? Is it MS? Is it a tumor? Okay. But then, let's say none of those are there. Well, a lot of times people are given these specific drugs. Okay, so sodium channel blockers, but there's a lot of side effects. That includes dizziness, rash, drowsiness, tremor, and so this is what we're typically looking at when it comes to like the workup, diagnosis, and then treatment. Again, history is just to rule out other problem issues, doing a full neurological exam, doing some other clinical work, checking the differential diagnoses, and then the medical treatment are these sodium channel blockers. They may do another therapy like gabapentin, which is for nerve pain. But these challenges are there are a lot of side effects. The kinds of side effects: hyponatremia, like a lack of salt, cardiac renal disease, women that are using oral contraceptives or planning on pregnancy, that can affect as well. And so then there's surgical treatment if that is necessary. And so what I like to say, so we're just going to stop that. What I like to say is that for treating trigeminal neuralgia in our office using conservative means, is there are options out there, right? We are working on decreasing the overexcitability of the nerve or the parts of the brain that the nerve connects to. And so therefore we can decrease sensitization to that touch or pain on that side, whether it be the right or left side for that nerve. It's rarely both sides. And so what's cool is that we've had some success with that, but it does take time, and it's definitely a slow process, because a nerve that, especially if this has been a chronic issue, it's almost more excitable, and the pathways that are causing this pain are more driven, more plastic, and so therefore we have to reverse those changes, right? So what we do is a variety of stimulation. We generally don't even touch that side of the face. We can do a lot of things with the arms, with the hands. We can do things with eye movements that are all affecting the parts of the brain we want to affect, and therefore decrease the excitability and the sensitivity of that side of the face, or that side of your face, but we're not necessarily touching, we're not provoking the pain. So we've had some success, and if you have any questions or comments with trigeminal neuralgia, you can leave them below. You can always call our office and get a phone consult with one of our great coordinators. And if you have any suggestions for future topics, I would love to hear them as well. Thank you very much for listening in today, and have a great day. Stay healthy.